Good afternoon, everyone. Welcome to today's webinar, Intermediate Care and Rehabilitation, helping people stay in a place they call home. Today's session has been kindly sponsored by Rotamaster. So before we get started with our discussions, we're just going to share a short film from them. Okay, that's great. If you want to get in touch with the Rotamaster at all their details are on our CMM webpage, or you can get in touch with us. So today's session will be recorded and available on our website next week. So you can share that with colleagues if they weren't able to join. If you are joining live now, we can answer questions for you using the Q&A buttons. Just make sure you pop those at the bottom of your screen and we will share those with the speakers and answer those throughout. So right, I'm going to hand over to Liz now and our speakers to introduce themselves and get discussion started. Thanks so much, Liz.
Brilliant, thank you, and thanks to CMM for hosting us. Very helpful to have events that we can contribute to and bring a range of partners to discuss some hot topics. And I think it's fair to say that intermediate care, rehabilitation, getting people home to wherever home is a hot topic, has been all year, always is all year, but is even more at this stage of the year in October. So I'm the Policy Director at the National Care Forum. We're a membership organisation for the not-for-profit sector. So we've got a wide range of members providing lots of different types of care and support, mostly across England. The thing that binds them is that they're all not-for-profit. And I've got a great panel with us today. So I'm going to ask them to introduce themselves before I tell you a little bit more about how the session's going to run. So let's start with Jenny Keane.
Good afternoon, everybody, and thank you very much for the invitation today. I'm the National Director at NHS England for Intermediate Care Rehabilitation, and I'm the Director with responsibility for the Better Care Fund as well. Looking forward, and thank you.
Brilliant, thanks Jenny. And then if we go to Jenny Cook.
Hi everybody, so my name's Jenny. I work for the ICB team in Leeds. My day job is the Director of Population Health Planning, but I'm also the lead for Home First, which is our intermediate care redesign programme in Leeds, and we're one of the national frontrunners for intermediate care.
Brilliant, thank you. Thanks for joining us, Jenny. Eileen.
Hi everybody, I'm Eileen Burns. I'm a National Specialty Advisor for Older People Services at NHS England, so that's a one-day-a-week secondment. I'm a geriatrician working in Leeds in the acute hospital and in the community. And in the community part of my job, I'm involved with hospital-at-home services, intermediate care, and some proactive care. So quite a wide range of those clinical services that I've got experience of. Thanks very much for inviting me.
Thank you for joining us, especially on a non-working day. And Renata.
Hi, my name is Renata. I work for Order of St. John's. We are a non-profit organization with 4 regions, and I'm a peripatetic operation manager. And I used to run an intermediate care unit within our organization. Thank you for the invitation.
Brilliant, thank you. So we thought this would be a very timely session, given that we've recently had the publication of the Intermediate Care Framework, the Community Rehab and Reablement Model, and we've been learning quite a lot about all the hard work across the 8 sites, I think it was, 8 Frontrunner sites for the Intermediate Care programme, whose work has fed into the framework and helped to shape the suggested approach that local systems, local authorities and local providers should be thinking about responding to, particularly given that we are moving into the winter months, when we know that the year-round pressures across the system increase quite significantly with the colder weather and with ill health. So we've got 90 minutes-ish, and we're going to have kind of 3 sections where we're going to hear different perspectives, information and updates from our various contributors on the panel. So we're going to start off with looking at setting the scene nationally, where we're going to hear a bit more about the national policy perspective and a quick look at the intermediate care framework. We're then going to have a chunk of time devoted to some local perspectives. So we'll hear a bit more from Jenny from Leeds and also from Renata to kind of bring the provider experience. And then I'm going to take Chair's prerogative and share a bit about some work we've been doing at the National Care Forum, which links into some sort of practical top tips and planning for the next few months. So if it's okay, I think we'll get going. We'll start with our setting the scene nationally. And first of all, I'm going to ask Eileen to give us the national policy. She's got 10 minutes maximum. No challenge there, Eileen. Give us the national perspective on older people in relation to intermediate care and hospital discharge from the perspective of being that specialist advisor. Thank you.
Thanks, Liz. Yes, I'll try and stick to the challenge. So essentially, just to kind of give a slightly broader perspective to start with and then sort of to narrow in. So I think we all know that there's a huge demographic shift that's been occurring over the last 30 or 40 years and will continue to occur, so that we are seeing more and more older people living into old age. Many of them are living into old age with good health and remaining independent and happy in their lives, but a significant minority of older people living with increasing levels of frailty, which means that they're at risk of developing those complications of frailty that we know so well. So falls, delirium, problems with mobility, continence issues, and they're very likely to be prescribed large numbers of medications. And I think it would be fair to say that nationally we've been slower than we should have been at recognising this change and actually devising policies to actually start to think about how services need to change to meet the needs of that part of our population. I think each winter that comes brings its own huge challenges, and of course we saw that really graphically last winter. So in terms of national policy, there is a recognition that we do need a comprehensive range of services for older people, which really are designed to provide a whole kind of joined up picture to support people to stay as well as possible within the community and within their own home, whether that home be an individual house, home, flat, apartment, sheltered complex, or whether that be within a care home setting. The aim is to provide support in a sort of public health type environment to help us all to age as well as possible, so that we reduce the risk of ending up with problems of frailty. And as an aside, we know that if you live in a socioeconomically deprived area, you're at higher risk of developing frailty and of developing it on average 10 years earlier than someone in a non-deprived area. So when we're thinking about how we target services, we need to be very cognizant of those challenges as well. So general support for people to age well, and then a service called proactive care, which used to be called anticipatory care, that you may have heard of. The framework for that has not yet been published, but is hopefully to be published very soon by NHS England. But in many parts of the country, people are already offering these kinds of services, which essentially are based upon certain specific steps. So you identify the cohort of people in your area who are at risk of deterioration, you offer them holistic assessment and care planning, and you provide them with the support that they need to hopefully reduce their risk of ending up in hospital. We need smooth pathways both in and out of hospital, and wherever it's possible for an urgent care need to be met in the community, then that's clearly preferable. So we know patients tell us that they much prefer to receive their care within their own home. Again, clearly their own home, whether that be their own building or in a care home setting. And now that we have urgent community response and hospital at home services being developed in many places around the country, we know that that is a reality. We know that hospitals are bad places for older people. Those of us who work in hospitals clearly have got a huge responsibility to try and minimise the unintended consequences of a hospital admission for an older person. But whereas people sometimes perceive hospitals to be safe, we know that people are at higher risk of falls, of developing pressure injury, not eating well, becoming more delirious. So we know there's a whole range of possible downsides to an admission. So if we can manage an acute problem within the community, that's absolutely preferable. But clearly, as I say, hospitals are necessary and sometimes absolutely appropriate for frail older people. And then we need to minimise those unintended consequences I've just mentioned, but also think about support that they will need to be able to regain as high a level of independence as possible and to return to their own homes as soon as possible. And that, of course, is where intermediate care and support comes in. So thinking about rehabilitation and supported recovery, and obviously Jenny will talk in detail about this, Jenny Keane, as we've got our two Jennies today, just to keep us on our toes. So I won't say too much more about that. I think there are huge challenges, as we all know, challenges in workforce, challenges in funding, and recognising those challenges and doing our best to kind of provide workarounds where we can, to think imaginatively and differently about how we provide services are things that we can do to try and mitigate some of those challenges. But I'm not going to sit here and try and say anyone has a rapid solution to those challenges. And I think we're all aware that regardless of governments, funding solutions are not going to be readily available in the very near future, unfortunately. I wish that was different. So a recognition that we need those different range of services that I've talked about, and also a recognition that crucially those services need to be joined up. So we need to think about how that works both on a personal level for that individual, how they experience those services in a joined up way, but also about the kind of structural things that sit behind that in terms of, for example, data sharing, shared clinical records, and so on and so forth. The services obviously are all completely interlinked. So if you receive proactive care, and you've had, for example, a review of your medication to reduce your risks of falls and make sure you're not taking too many anticholinergics that are going to increase your risk of confusion, that obviously will hopefully reduce the risk of something happening. But that's also an opportunity to talk to you, to introduce the concept of urgent community response in a hospital at home service, to give you an opportunity to start to think about what you want for yourself in the future. So your personal approach to risk versus benefit of an admission, for example, your personal wishes regarding as you move towards the end of your life, how you want to be cared for, your wishes around place of care, for example, and so on and so forth. So that proactive care will feed into the response we offer that person. We know that relationships are crucially important to older people and continuity of care, and that sort of relation aspect is something that people really, really value. And that's something, again, that we need to sort of keep at the heart of our planning when we're thinking about how we implement this range of services. Clearly, there are going to be big differences. I've already talked about in an environment, for example, where people are living with high levels of deprivation, will provide different challenges from perhaps a rural area where the challenges may be not such high levels of deprivation, although obviously we are aware deprivation definitely does exist in rural communities, but the challenges may more be around geography. We may want to think about how we use some remote tools, both for monitoring and supporting rehabilitation and recovery, and also for supporting people who've had an exacerbation of a care need, perhaps an urgent care need. So it's thinking about how we'd use a range of different services in different contexts. I'll stop there. I'm really sorry to say I can't stay for the whole of the webinar, but I'll be very pleased to try and answer any questions in the chat while I'm here with you.
Brilliant. Thank you. Do you know, I'm glad we're recording this, Eileen. I suspect that's probably the most comprehensive overview in a few minutes of how it all fits together. For those of us that are not immersed in NHS world and dip in and out quite regularly, that's really, really helpful. Thank you. So Jenny Keane, do you want to give us a quick overview of the intermediate care framework and the so what bit? We've got it. So what is it and so what?
Yeah, thank you, Liz. Yeah, Eileen's my go-to person when I want an answer. So I would totally agree with your reflection. I usually try and bribe her with a glass of something cold, but yeah, I do use my sounding board. So this is going to be a poor follow-up. Liz, I'm going to give a very brief overview of what the main points are, and then I think what you really want from me is, what does this mean? How should this be different? And I'm not going to, if you don't mind me saying, insult your audience by teaching them what they've already, or reading out what they can already read online.
Thank you.
You have seen the intermediate care framework. I think it's important that I say that it's a framework that's for rehabilitation, recovery, reablement in the step down components, so on the discharge element of intermediate care, but there is very explicitly a commitment that this is phase one, or that, you know, this is the first piece. That was a very active decision. That was a decision that was met with quite a lot of resistance with the, why are you not covering the entire pathway? And the reason why that was an active decision was that there was already quite a lot of really good policy work on the admission avoidance piece, particularly the success of virtual wards and urgent community response. And it was felt that we didn't have the same emphasis on this. So, I mean, I think one of the key messages for me that I hear from Eileen is that this is, you know, it's the recognition of the sort of smorgasbord of services that are required in this area and how we join them up seamlessly. So, you know, accepting all of that, this framework is very much trying to bring the back door up in line with the front door in terms of policy and service provision. Within the framework, we have 4 key priority areas. So I'll briefly mention those, and then I'll go on to the bit about what should be different, what should we be seeing and starting to hear now that is different. So the first of those was demand and capacity planning. It seems really, really basic, but it is a desire and a recognition and a really strong recommendations to systems that we need to really understand what is the demand for these services, and that we should be proactively planning the capacity for those services in a longer time frame, and not relying on retrospective planning guidance when we know that we very often place people into pathways because that's where we had capacity. So it's a real focus in terms of future planning, and there's a really strong recommendations around the need for the type of leadership and infrastructure that's needed around that demand and capacity. The second one is around the rehabilitation and recovery reablement model of care. You could argue what's new about it, except that we haven't previously had any sort of national guidance or drive or support towards community rehabilitation. And every time I say rehabilitation, I mean reablement and recovery in that space. That model is very strong in terms of workforce. It could have been called a workforce priority. It's about repositioning the therapy workforce with a focus on the workforce and the type of models that are needed to shift care from multiple assessments in an acute setting to provision of service in a not acute setting. I am deliberately saying a non-acute setting rather than saying bed or home, because this is a pathway that is agnostic of setting. So it's about delivering intervention. The third one was around care transfer hubs and a commitment that we have that there will be functioning care transfer hubs everywhere across England, and I'll go into what they should look like and what they will do. And then the last one, which I think Eileen picked up on as well, is data, and that we really need to prioritise and keep pushing the need for improved data in the space right to the top of the list. So with those 4 priorities, what should we now start to see that's different to what we've done previously? How has that conversation changed? But I think the one that will be of most interest to this audience, and if I'm honest, it's the one that's of most interest to most people, is the demand and capacity planning. So there is sort of the demand and capacity planning. Last year, we had an ask within the Better Care Fund for all at a health and wellbeing board footprint for demand and capacity planning to be done for intermediate care. That wasn't assured. This year it is. It was done, but we didn't go through an assurance process through it. This year that is happening. We brought the demand and capacity planning, we brought it forward in timeline so that it would be done well before winter, so that systems had the opportunity to do that. We had a real ask within that demand and capacity planning to quantify the capacity that you need for the demand that was coming into your area, rather than just listing the capacity which you were traditionally able to access. It has been fraught, and it will take, I think it'll take a number of cycles to get it right. People are still, we have systems are telling us that they have challenges in accessing the demand data from a health perspective. Some places are telling us that they're filling in the capacity short term, even though the funding is longer term now, because that's just the culture and the behaviours that we're used to. And I think the other thing that's really important to say, and it's important for us, is that we are next year aligning the planning process, the NHS England planning process, with the BCF planning process. So there will be one timeline, and we're aiming towards doing this capacity planning and resource planning once across the space, and not asking for two returns. It's very easy to say. That is an exceptionally challenging thing to do. The care transfer hubs, I will go on to that bit. So yeah, so the data, and I've mentioned that the data is absolutely imperative. Within the intermediate care framework, there is a commitment that we are working towards a national standard. That national standard is about being able to measure that the capacity will be available in a timely way when somebody needs to step into it. So in other words, when somebody no longer needs to be residing in an acute hospital, that the capacity is available within intermediate care services to pull them out of hospital. And we are aiming, and I'm saying aiming, for that standard to be within 24 hours or within the next day. So it's about having the planning available to move people into the smorgasbord of services that are required within that next day, 24 hours. Data is absolutely imperative to that. It's not actually the commissioning or the demand and capacity planning, it's the data. So we can start the clock with the discharge ready date, and some of our measured with some of our no criteria to reside. But the services in this area are, as we say, really devoid of data. And the reality is, if we can't count it, it doesn't get seen. If it doesn't get seen, it doesn't get prioritized. Bottom line, it doesn't get funded. It gets pushed down the line. So I'm always fearful that as a sort of NHS director, I get seen as the wanting to count the beans, put a clock on everybody. The driver here is that, one, people residing in an acute hospital decondition. We need a data form that actually pushes this up the agenda, that changes that behaviour. I'm very strong in my belief that people should not be residing in an acute bed unless they need to be there. I'm more agnostic about whether that onward care has to be at home. Ideally, it should be at home, but there are really good bedded intermediate care services that can provide that higher level of rehabilitation needs that move people quicker towards home. That data piece is really important for ensuring that we've got that timely flow. So I've done what I said I wouldn't do. I gave 4 things and then I jumped into explaining some of them more than others. But if I go back a little bit to the care transfer hubs, what should be different about those? So what's different about those is that we have provided guidance to systems that say that those care transfer hubs have to be made up of health and social care workforce. Specifically, we need social worker and, you know, some of the sort of decision-making capacity available within those care transfer hubs. And they need to have the autonomy to work with reducing, I don't like the word overprescription, but reducing the overprescription, and being able to, the care transfer hubs, as we've described them, should have access to all of the demand that's coming in from whether it's one acute hospital and one community trust, 2 acute hospitals, and being fed out into 4 local authorities or 1 local authority, depending on your footprint. But the care transfer hub needs to have oversight of all available capacity, regardless of the sector, to be able to match the demand going in to be able to manage the demand. We envisage that as the capacity and demand planning improves, that it is from the care transfer hub that we start to pull that information around place-based demand and capacity planning. So the care transfer hubs are not about signposting or brokering necessarily, even though that's a function, and it should be the complex discharges that go through the care transfer hubs. Liz, maybe I'll stop there. I think I've done my usual and jumped back and forth on my own timeline.
Thank you. May I ask a couple of questions, Jenny, before I then get some reflections from our other panelists? So I really get the data focus and I really understand the challenge of demand and capacity planning. I think that is that is a tricky thing for local systems and local areas to do. I guess that from a provider perspective, I've not heard a single of our members say that they've had any involvement in that process. And I wonder, your point about data being absolutely essential, I wonder if we're missing a trick here in, oh, wait, where's she gone? Oh, yeah. I wonder if we're missing a trick in how we are using the sort of strategic knowledge as well as the actual information from the provider sector in the locality to support that demand and capacity planning. Because I think they will have some useful intelligence that that won't be visible to the system, partly because it's quite hard to get data from social care to be visible, and we're working on it, aren't we? But I just wonder what, in that ideal world and your several iterations of the cycle, what does that look like from your perspective of getting an across the piece health and care view of demand and capacity planning?
So I think I think that you have asked the question which is core to getting this right, Liz, which is hardly surprising. But when we do our BCF demand and capacity planning, it's new. I mean, this year is probably the first cycle of it. We have a universal support offer, which is going down, supporting systems to do this at place level and local level. But Liz, when we've gone down and spoken to people, you're right, health isn't familiar with what they need, who they need to talk to, and what they need to do to commission the capacity that they need for their demand. And from a social care perspective, we're hearing that they don't know what the demand is expected to be over the next year or so. It seems very flippant of me, Liz, if I say something like what we're really doing is corralling people into the same room and into the same space. Jenny Cook will be able to describe this beautifully, but you know, it could be as simple. You don't need to share the data. You just need to bring people into the same room with their respective laptops to actually start to do the planning template so that it can be done in real time. Now that sounds really, really simple, Liz, but it's not. But those data sharing agreements can be done at a local level. But
Okay.
it's pushing it. It's trying, from our perspective, what we're trying to do is to challenge people to not be reactive and short term. Now, we keep hearing that the funding is short term and reactive, but actually, even for the long term funding, the planning seems to be very short term, and we're really trying to drive down the reliance on spot purchasing or short term buying of capacity so that we can actually see the capacity that's there, and then also start to think about surge capacity planning as well. I don't know if I've answered your question, and it's not because I'm not trying to.
Oh yes, sorry, Eileen. Thank you, Jenny. Eileen, I was going to say goodbye to you shortly, but thank you very much, Eileen, if you've got to go. So thank you for coming and delaying your non-working day to being fully non-working. So that's a good prompt to ask Jenny Cook for kind of your perspective around that demand and capacity challenge, because I think, you know, and Renata will probably give us an example shortly. I think that care providers are getting the impression that they are A, not part of it, and B, potentially having services kind of decommissioned in the run up to winter, which seems very strange. So I'm kind of interested in how you're approaching it in Leeds and what your reflections are for the challenges that Jenny Keane has raised, at this being hard to do, and it needs people in a room and trust and relationship.
Yeah, absolutely. I'll maybe just talk for a minute or two about, just to give a bit of context to the programme itself in Leeds, how we're organising ourselves around it, and then I get into some of the detail about, I guess, care provider engagement as part of that. So Leeds is our Home First programme, which, like I said, is our intermediate care programme, has been going on really for over 18 months, and it started with a really detailed diagnostic of what was happening within Leeds. So we're in a position where our flow was really pressured, people in all the wrong bits of the system, people falling between the gaps, you know, lots of very high cost and variable outcomes across our intermediate care in the broader sense. So this wasn't just a acute hospital issue, which is where often, you know, it shows up itself in terms of no reason to reside, but actually what we also saw is real variation in our intermediate care provision outside of hospital, particularly in terms of lots of reliance on beds and really significant variation in terms of outcomes, long-term outcomes for people. So we spent quite a bit of detail getting into what was currently happening with services, and to do that we looked at lots and lots of data, but we also brought teams of people together and existing providers right across, from care providers up to acute hospital, to look at cases and say, well, what should have happened to this? What did happen to this person? But what should have happened in an ideal scenario? What would have been the right outcome? And did that from the bottom up to really understand how things could be different in Leeds. We then set out a vision for the programme, which was to deliver a much more integrated, joined up, person-centred intermediate care in Leeds, and designed a programme of work around 5 key project areas, which I'll just touch on briefly. So the 5 project areas is 1, active recovery at home, which is developing much more integrated, joined up, short-term, home-based rehab and recovery offer that has the right capacity and approach to support people to achieve more independent outcomes. So really focusing on effectiveness of those services. Enhanced care at home, which is really connected, which is about fast and effective care outside of hospital, to safely reduce unnecessary admissions and help people return to home quickly. So that includes some of our virtual ward offer as well. Rehab and recovery beds. So we've got a whole range of beds in Leeds, and redesigning those intermediate cares to maximise both the number of people that can return to their own home following a short stay, a short term in bed, and ensuring that there's much more standardised outcomes for people that are in those beds. Transfers of care, which is about redesigning interfaces between services for simple, quick, effective pathways and improving support to people who are discharged from hospital and their families and carers. So really thinking about not just about the transfer of care hub as a standalone service, but all those interfaces across a really complex health and care system. And then lastly, I think the bit that we've touched on a lot today, which is about system visibility and active leadership. So we've worked really hard to develop effectively a tool, a dashboard that gives us live data around lots of different bits of the system to help us understand what's happening in a really live and tangible way. But the reason that it's not just a system visibility tool, and it's also about active system leadership, it's about how decision makers then use that data to inform the decisions that are made in the system on a kind of hourly, daily, weekly basis, and trying to move us less from reacting to what happened yesterday to planning about what's going to happen in the next 1 month, 2 months, 3 months, 6 months, etc. So that's a bit of a flavour of the programme. The messages from that is it takes a really long time to deliver this level of change, and we're 18 months in, and we've still got at least another 6 months to a year to go to get to the point where we think we will have achieved all the outcomes that we've set for ourselves. But we've seen some really great results in the short term. So we're starting to see people coming out of active recovery services with less kind of care package requirements at the end, so been more effectively re-abled and able to have more independent outcomes longer term. We're seeing the length of stay in our community care beds reduce significantly in the pilot sites that we're working with. And again, that more people from those who've been in those beds are able to return to their own homes at the end of that stay in those beds. And the knock-on effect into the acute is a significant reduction in our overall no reason to reside, the equivalent of kind of 2 wards closed over the last few months. So going into winter in a much better position than we were last year for sure. So a long way to go, but we've seen some really amazing results from that work. In terms of the way in which we've been working with care providers in Leeds is, I guess, starting off with just that initial recognition that there's a really wide range of care providers in the system, and I know that's different in each place, but actually just acknowledging and recognising that. We're working directly with Skills Reablement, which is one of our in-house care providers, care homes as part of the rehab and recovery beds, third sector partners, and home care providers to support us around that capacity and demand piece. We've recognised from the off really that home care and care home providers and the third sector are really key in supporting people as they come to the end of their intermediate care. So that kind of transition from that short-term rehab and reablement intermediate care piece into long-term care needs, that connection is super clear. So we can't just focus on getting intermediate care right, but again, that transfer of care hub, that transfer of care work is really, really essential. And we also know that it's often that the home care and care home providers are the people, they see people more than often our intermediate care too, that they know the patients better than anybody else, and particularly as we try to do more of that proactive piece. So not just intermediate care as the destination from where people end out of hospital, but actually picking up those escalating care needs, that we need to work really closely with those providers to help us identify needs and work together to put in place joint plans. So a lot of that work around enhanced care at home and active recovery has been starting to do that work with providers to understand how we use their knowledge of people and patients in Leeds and act on them much more closely and create those really clear links, escalation routes, and relationships is often what it's about, knowing who to call, when to call, how to get hold of people at the right time. A big part of our programme has been about simplifying existing stuff, because the last few winters in particular that have been really pressured, we've added and saw gaps and put stuff in and seen another gap and added another thing, and as a result it's an incredibly complex web of systems. So trying to track that back, so actually a carer in a person's home who's noticing escalating needs is really clear which number to ring and who to speak to if they need help, rather than, oh, is it a Tuesday at 2:30, then I need to ring this person, but if it's a Saturday at 7:30 it's somebody completely different. More broadly, we work with the Leeds Care Association, which represents some, although not all, of our care providers in Leeds. So we have a really regular forum with that group. And we've had a two-way dialogue about Home First and some of the winter and BCF planning as well that we were touching on. We have a separate but aligned piece of work in Leeds as well, which is looking at our community health and wellbeing service, which is a potential new way of commissioning and delivering home care more broadly. So that's, yeah, a bit of an overview about Leeds and how we've been working today. I think there's still more to do, and would like really welcome kind of conversation and ideas and approaches and suggestions from others on the call today. Unlike some other Frontrunner sites, we aren't contracting with providers to develop our core offer, so we're not set with, this hasn't been a commissioning or contracting program of work. It's been a let's work with our existing providers to redesign what we currently offer and then adjust our commissioning and contracting to ensure it helps us deliver that. So it's a slightly different model to a contracting-led model, but there will obviously be some contracting commissioning implications at the back end of it.
That's fascinating. So I think from a provider perspective, it's great to be involved in the conversations early on. And it's great to kind of see what you can. So if you think about about how providers are configured, certainly from the not-for-profit sector, many of them offer a portfolio of services. So actually, and that usually comes from the sort of voluntary community side of things, because they have evolved to respond to community need as they see it, because that's often the ethos of the organisation. So they may accompany people on their ageing journey via a number of different services, whether that starts off as sort of community voluntary volunteering and, you know, getting together services, through to potentially housing and supported housing and extra care housing, through to care homes. So kind of understanding what the landscape offers, not just in terms of quantity, but in terms of ethos, I think is really important. And certainly the providers we work with, not all of them, but, you know, quite a lot of them are keen to have that strategic influence, I think, in the localities that they work, so that they can bring, as you say, that really good understanding of people who they see every day. They can bring that to the party, and you can gain from that insight. So let me ask Renata just to, I guess, just to comment on the capacity and demand planning idea, first of all, and then we'll get a bit more detail around the provider perspective on, from your view, what works well and what doesn't with the intermediate care interface, I guess. So are you aware of Order of St John's being involved in any of that demand and capacity planning across the patches that you work in, Renata?
So I'm not, and I think we feel a capacity tracker to keep both health and social care involved within our beds, but for what I'm aware, we were never invited to any forum or anything to support the new frameworks that are being created. I think the intermediate care is a key partnership for all the providers, is a need for it, and where a person is at the heart of everything, and our aim is to send them back home, follow some rehabilitation, and the last thing we want is for increased readmissions in hospital, but what we are seeing is an increased pressure on these beds. Is not enough of them, and therefore is often some pressure to release them early home, which can then see an increase on readmissions. But saying that, we actually have improved our relationship with our partners within NHS, and the communication, like Jenny said, is vital, is going back to simplifying things, creating these conversations, open and honest conversations. When I initially start to manage these intermediate care beds, the relationship was a bit broken, and we straight away identify a need for regular meetings where we will restructure the way we work and the way they work, because if they do not have awareness of our legal requirement within as a provider, then they were asking us to work a bit quicker, and we need to have things in place, and therefore by letting them know what is our requirements, we could then adjust their requirements as well as ours, and work together to enable this person to recover and have the necessary time within our intermediate care beds. One thing that is surprising, like you said, is we actually have location that they are they are removing the intermediate care beds, and we are just entering the winter. So I do not know the ins and outs of the reasons of that, but for my experience, is a need for them. So that is my experience, really.
Thank you. So Jenny Cook, is there anything else you'd want to tell us about the kind of front runner insights that you've got in terms of, I'm just thinking about Renata and probably quite a lot of the people listening who don't quite know how to get into the system discussion. You've obviously spent quite a long time, well, 18 months, probably longer, working this out. So what are there some things that you would recommend to our provider audience here about the doors to unlock or the questions to ask, I guess?
So I think, well, one of the really key learnings and key pieces of work has been around that system visibility, really understanding what's happening across providers, and creating that culture of transparency around that data and information. And the more you know, so we've got within our data set there, so we've got daily flow from all of our intermediate care beds, for example, that helps us understand exactly where people are at, and delays and length of stay and outcomes data. And it took a long time to get to, I guess, one, there's a technical element of that which I won't go into. I'll pretend to even understand all the technical elements of that, but you can imagine it was quite tricky in the IG, etc. But I think more importantly was that I was building that trust and culture between partners, that this isn't a performance tool to say, oh, you know, your length of stay is too long or whatever, but it was about getting that shared understanding of what was happening in the system, and the more in which all partners can come to the table with that kind of learning mindset, transparency of data and information, really helping understand what happens across the system, that the better. It's obviously different in different places, but we certainly had to work hard with our providers and leads to get those data flows in place, and I think everyone's now seeing the benefit for it. But it did, you know, took a long time to get everyone to that kind of trusting place of how's the data going to be used, what's it for, and now it goes right down to patient level as well. So actually we can now work with people in those bed bases around individuals and say, well, can we help escalate whatever the need is for that person while we're not able to get them home? It's an equipment issue, right? We can see that right down to patient level. Let's talk to the manager and work together around it. So it's been a really, really vital tool. And I think that's a great place for kind of people to start with around some of this work.
Okay, that's interesting. Actually, that's a very interesting reflection. I think, Renata, you were going to give us a little bit more detail on some of the work you'd done around kind of building that relationship in the discharge part of the system, and kind of rescuing in a situation that perhaps wasn't so great, to support your intermediate care offer and to be delivering on those outcomes. So you just want to tell us a little bit about some of the things that you found that you needed to do, and the things that worked and the things that didn't.
Yeah, so like we were saying, sometimes it's going back to basics, but and is what we done at OSJ with our NHS colleagues, because if it's not working for us, clearly will not work for them, because we both depend on each other. So initially, mainly in winter months, as we know, the increased pressure in hospitals, and therefore was more risky for unsafe discharges, and we were receiving some patients with high expectations from the team at NHS, and we raised this with them, and they were very proactive, I must say, to escalate it. But within a local area, we needed to do something about it, and doing something about quicker, because people were requesting things that unfortunately due to workforce, as we know, physiotherapists, OTs, nurses, and in is lack of them within any area, I believe. And therefore we try to set up expectations, and that was, if people know what they are coming from for within these intermediate care beds, they don't think, for example, we had families that will come and think they will have physiotherapists 24 hours a day. We don't have that within intermediate care beds, and even in hospital is so we straight away told them that is several things involved within these intermediate care beds. We explained what these intermediate care beds are, because they were sending patients to us that weren't aware what they were there for at times. So we create a leaflet, and both social workers, physiotherapists, and the Hub Discharge team within our region was part of the creation of this leaflet. So it will answer to the main questions that these residents and these patients and families had when they will come to an intermediate care bed. And soon as we start to give that ones out, what is a very simple thing to do, it was not as many questions, was not as many confusion about what was next, who was dealing with what, because discharges are complex and they need to start on the first day, or as soon as they are admissions, we need to start to plan for discharges, and that is what we normally do, and I believe is what it should be done by all the teams, and we do it in our intermediate care units. The other thing is sometimes is like I explained, even though is an openness to learn about social care, the health care teams in hospital sometimes still think they know best, and this is not any way a negative thing, because sometimes they do, but is lack of knowledge around social care, and where we could place them, because discharge are quite complex, and sometimes there's many people involved in them, and we don't have pharmacists on site, for example, so we cannot access medications as quick as in hospitals, and have this awareness, because they will send these patients sometimes with lack of medication that they thought we could source them on the day, and we can't because we don't have a pharmacy open 24 hours local, so we will need to wait for the following day, so which will put the team in some difficult situations, but the Hub team was within the intermediate care unit, was always the mid person that will liaise with the wards, liaise with the hospital, and get us the help we needed. So that team is vital for these intermediate care units, and we couldn't have done it without them, to be honest. So,
thank you. Yeah, thank you. Some very practical challenges there. So either Jenny or Jenny, thinking about, so you've been recognising, Jenny Cook, that challenge of tracking people through their intermediate care journey. You talked about Home First as the kind of broad name of the programme, and then you had your strands underneath. One of the things that's very interesting is that there's a temptation to think that home care can solve lots of challenges for people as they leave hospital. And often even with the most intensive package of home care, you've still, you know, you've got 4 hours a day, you've still got 20 hours a day where you're not supported. Have you, in your design of your services that are helping people at home, have you been trialing a more intensive home care approach? Or is it that joining up of home care and the kind of rehab workforce that you've been focusing on more?
So I guess our overarching aim is around increasing independence effectively. So how do we get the best long-term independent outcomes for people? But as part of that, testing a kind of whole range of different approaches, from the way in which those kind of care packages and ongoing care is agreed and planned in hospital, or in other settings, to what the offer is in the community as well. So part of that work, the active recovery work in the community, has been a better integration between the kind of health element of rehab and the reablement bit in the local authority, to make that the best use of that, more joined up, more streamlined, like clearer offer for people there, and that also connection and handover into those long-term care packages as well. So I don't think there's been a specific test of change around more intensive kind of care home support as an option, but one of the things that we've been tracking through all of our changes is what the effectiveness of
I was going to
that
ask you about the
intervention is.
long-term outcome. Yeah.
So a key measure for us is, and we describe it as like reablement rehab effectiveness, and the proxy of that is what's the long-term care package needs of people who've gone through that service, and also what's their long-term destination. So one measure is like, do people stay in their own home, or do they go into a bedded setting long-term, and what level of care package do they have when they kind of come out of that intermediate care into a more long-term package. What we've seen from our trial sites is about, at the minute, a 30-minute reduction in people's long-term care package from a different active recovery office. But that's a whole suite of things. One is getting people out of bedded settings sooner, and it's then a different offer when they're in their own homes, and all of that is adding up to minute to an average in our pilot sites of a 30-minute reduction, which, if you, from a kind of economic sense, when you add that up, that's a really, really significant reduction.
Is that 30 minutes a day or 30 minutes a week? Or
a week,
yeah,
30 minutes a week overall reduction at the moment.
Yeah, I mean, I think it's really great to hear that level of ambition for independence for our older folks, because I think certainly my personal experience, and often what members will tell us, is that the focus is more on other metrics, which are easier to count. And actually, if we can have a level of ambition for the overall level of independence that we aspire to for our older folks who've ended up in hospital one way or another, if the focus is their long-term independence, I think we're onto a winner. I'm just not convinced that happens everywhere. So it'd be fantastic to hear how you get on over the next sort of 12 months. How long are you tracking people for?
Well, we've started tracking them. I mean, this will become an ongoing measure, basically.
So an individual. So Liz goes into intermediate care, then gets home. How long would you see Liz's outcomes? Would you keep an eye on her for 12 months or for 18 months, or?
I'm not sure, actually. I'm not sure what the time frame is that we're because everything's kind of currently quite live, so it's in the month period at the moment. But I think we will continue to track that over like 3 months, 6 months, 9 months, 12 months over time, and become quite a regular measure that we look at as what you say, as a way that we might look at, no reason to reside, or these are the kind of acute hospital, like, that becomes a core measure for the system. But I think you're right in terms of, like, we've just come out of a delivery group session with our team leads, and one of them was, we were just reflecting on like building that culture. It's really deliberate, and it requires people in every MDT asking the right questions, putting the right challenge in, having the right training and support. And it can be as little as having a couple of people missing from that MDT, and actually that ethos falls away. And so it's, you can't
go down a different rabbit hole.
It's really, can't keep your eye up. You can't take your eye off it, basically, because it is a big shift in lots of different people's kind of culture, behaviours, ways of working.
Yeah. Fantastic. I can see other Jenny's got a hand up, and I was going to come to you, Jenny, because I know you've been listening and taking notes, and I'm interested in your reflections.
But I think in answer to the question about, let's not just count time and units, one of the things I think it's worth referencing here is when I talked about aligning the planning guidance from BCF and the NHS England planning guidance, within the BCF guidance, there are 3 outcome metrics. One of them is the number of people who remain at home 91 days after they have had reablement. Now, that is the metric that's within the BCF, and that's partly why we are trying to align. Now, so not all services are funded by BCF, but it's why we are trying to align both the planning processes so that we can bring the best of either. And while I'm not suggesting for 1 second that that is the best outcome, but it at least starts to talk about the piece that Jenny Cook was talking about in terms of building resilience at home and trying to keep, that home first and keeping people. Now, and this applies, I think, not just necessarily at home, but where the patient calls home. And it, everybody has said to us, Liz, as we go have these forums and these discussions, what about the admissions avoidance? How are you actually making sure that the work that you're doing on the back door step down is actually helping overall system flow and not? So I think as we join up those planning processes, we will be we already have the 91 days. It's just not on all of the service. It's on local authority commissioned reablement, but we need to start pulling that then across all of the services. So not promising it today, tomorrow, possibly not even, hopefully by next financial years, we'll be making progress to the next lot of planning guidance. But everybody has told us that, Liz. Everybody's told us when, and that we need to do that.
Yeah, and I think so. Not to add to your metric woes, but just thinking from personal experience. So people being back at home is a really important measure. Absolutely. People being back at home with a very reduced level of mobility or independence, however, hasn't served them well. Might have served the system, but it hasn't served them. So when Jenny Cook's cracked it in Leeds with understanding a little bit more nuance about that long-term outcome, then I think we might come back to you, Jenny Kay, and say, so knowing where you are after 91 days is brilliant. Knowing if you're a lot more or if you've retained your baseline level of independence versus got a lot more dependent, that is also a very interesting question. So I have got a question in the chat, but I'm just going to take Chair's prerogative briefly because I feel this is my opportunity to talk to you about our blueprint. Oh, and I was going to share a slide, but that's been disabled. Still, let me just talk to you briefly about some work we did with the Intermediate Care Programme and with the Care Provider Alliance. So the Care Provider Alliance is a bigger grouping of membership organisations. So it's not just National Care Forum and the not-for-profit world, it's lots of the different membership organisations like the Home Care Association, Care England, the National Care Association, so big and small. And because we were quite worried about what appeared to be a philosophical shift to really being quite anti accommodation-based intermediate care settings, with a view that they were not doing a good job and potentially were increasing dependence and not maximising independence, we went to talk to our members to ask them, so people like Renata, at Order of St John's, people like Belong, who run a whole range of different types of services, people like WCS Care in Warwickshire. We went to talk to them about what they thought were the really important ingredients. So if you're Jenny in Leeds and you're thinking, okay, I've got my strand of intermediate care services that are offering accommodation-based places for people to spend a short period of time with their recovery and reablement, what should you be looking for and what should providers be delivering? I probably can share a slide. Let's see if that works. Can you see a slide that says Intermediate Care Programme? Yeah. So what people told us was that there are 5 key ingredients, and that if you are a provider who is wanting to provide really great quality intermediate care, these are the things you should be considering. And if you're a commissioner or working in partnership, these are some of the things you should be asking about. So, you know, when you have got an accommodation-based setting, you've got a 24/7 environment, which means you've got people around all the time, and you've got the opportunity to create a physical environment as well as a workforce environment that can really promote rehab, optimum activity, and really focus on recovery as well as reablement. And you can start to build confidence for people, as Jenny Kay says, and as Eileen said, actually, being in hospital is really not great for you when you're older, and the longer you're in, the less great it is. Then thinking about our workforce, so I know Renata's done work around this. You need a different mindset of your staff because you've got a rehab and recovery mindset. And Renata, you know, mentioned the importance of everybody pulling together to make every interaction with your person who you'll want to get home in a few weeks a rehab interaction, and take those opportunities to build confidence and increase independence. We've talked across the board about that multidisciplinary aspect of what we need to do to create the wraparound team to respond to that person's needs, aspirations and desires from day one, when they're, well, actually before they've moved into the setting. So we're constantly planning for their journey home and all the things that need to happen, and unlocking those barriers that Jenny Cook mentioned about things like equipment and about housing. And we've not really touched on housing actually, but housing is a really key element here of the partnership that we need, because as well as thinking about adaptations and things that people might need to make their accommodation more accessible, there's also the whole massive issue of poor quality housing, and a lot of older people live in poor quality housing. So there's lots of things that might need to get sorted on a practical level, as well as thinking about that ongoing care. We've talked a lot about systems and data, and being able to share data, have the IG and the tech in place, and to be able to communicate effectively on an ongoing basis. So, you know, our providers need to be up there in terms of enabling tech and communication. And then we haven't really touched on it very much, but in order to deliver a great quality intermediate care service, you are developing it, running it, staffing it in a very different way to a long-term care setting. You need different things, and you need different kit, and you need a different funding and commissioning arrangement. So if you're going to invest as a provider in improving what you do, making a great offer, then you need to have a long-term funding and commissioning deal so that you can sustain it. I think it's very difficult to do that on the short-term funding that we talked about. So I'm going to stop my NCFR and CPA pitch there, but we designed that with a view to helping everybody understand what really good intermediate care could look like in an accommodation-based setting. It'd be great to know if you think it would be handy to think about what that might look like in a home care environment. Be interesting. And before I take one of the questions in the Q&A that's about training, just wanted to get some reflections really on what else you think might be helpful from the provider sector in terms of us being ready to respond to that capacity and demand planning, because if we haven't been involved in it, you can be pretty sure there might be some immediate short-term requests, urgent requests. So what are your kind of top tips around practicalities for coming into winter? I'll start with Jenny Kay.
Oh, I'm already off mute. Yeah, so my top tips for winter are actually, you know, I am going to sound like a broken record, but it's being able to describe the capacity that you have everywhere, and I mean that in every sector, in a way that's easily understood. So I think very often we talk about X number of beds and X number of care packages without actually giving a sense of what additional capacity does that mean. So 10 beds, if you've got people in them for an average of 10 length of stay of less than 2 weeks versus on average 3 or 4 weeks, are very different quantums of capacity. So you need to be able to describe the capacity you're providing rather than the stock. So I think that's one of the things I would add to it. I think it's also important that when we talk about winter, we really dial in the timeliness, because you can have a lot of capacity, but if the capacity isn't available in a timely way, it really isn't capacity. And then the old bugbear, Liz, I think the thing that we really have to start talking about is, and bring it into the conversation, is workforce capacity and workforce caseload. So we talk about needing additional therapy workforce, social care workforce, nursing workforce, but we're not very good at describing how many additional of what type of workforce is required for X number of patients. Now, I can't do that, so it's a bit of rich of me to expect anybody else to do it. But I'm suggesting, that is the language that is really helpful to planners and commissioners, because that's what's really, really important. And I think it's the constant visible leadership, which I think Jenny Cook has reflected as well. I don't know if I think it is advice or key piece, Liz, but we have to be comfortable in being in the uncomfortable place. I have got called out in some of the national publications, you can probably guess which one, by saying it's not, the cozy relationships aren't necessarily the ones that work. You have to actually be prepared to have the difficult conversations and that accountability conversations. That's why I like being on these forums, Liz. We're able to have those conversations and have a proper, challenge and progress the agenda. And I think we've done that over the last year. So my top tip is really to continue with that, challenge each other in this space. We're far from there, or far from close. We're not even halfway there, Liz. So we need to continue that.
Well, I will still be here. So, Renata, you've got your hand up.
Yes, so I was just within a provider perspective, I think very pleased to hear, Jenny, these conversations are really necessary and they are very, very interesting. But in terms of a number of which nurses or physios is needed for how many patients, within a provider perspective is quite difficult to quantify, because depending of the dependency of the patients that you are getting from the hospital, I believe. So if we as a provider, and we had discussions with our hub about it, and mainly around physiotherapists, how many we need, and sometimes one was enough, because not all the beds need physiotherapist support, but sometimes we will get and admit patients that needed more support around physiotherapists. So we probably one is not enough. So I think it's very difficult for us as a providers to get the commissioners that number.
Yeah. And I mean, sometimes, so, potentially one solution is to think about the commissioning and funding model that enables providers to support their own team. Certainly some members have employed physios and OTs on the basis that they, they're dealing with a sufficient scale and volume of people that they can predict that they will need at least one physio or two over the year. And then actually what that helps with is less pressure on the community service, But you have to have that stable funding and commissioning environment, don't you, Renata? It's
I was going
hard to
to
do that
say
without
that,
you've got
I was
to
going
have some
say that
guarantees up front. Yeah.
if you're going to discommission or have plans to discommission beds in the future, then it's pointless to have that investment in terms of provider, because then what you're going to do with that workforce that you created for that service that is now no longer needed. But it's a very interesting area to discuss.
Yeah, yeah. So Jenny Cook, I'm going to ask you one of the questions that's in the chat, and then I'm going to ask you about your top tips. So Laura in the chat asks us about what specific training around reablement and rehab do we think is really successful? It's really important for successful intermediate care. Did you have this discussion as a front runner about what you want, a kind of minimum standard of rehab and reablement expertise?
Yes, although I don't think I've got all the details to hand to be able to answer really clearly, but it's definitely been a focus of the work is for our non-registered staff is what's the skills required around rehab and reablement to best support people. And there has been work with our OTs and physios and supporting people around that. But I haven't got it to hand the exact kind of specificity around that training, but it's definitely been a feature of the work that we've done for sure. It's been a really important feature of the work.
And Renata, from your point of view, when you're thinking about the people that are staffing your intermediate care units, what do you think is the kind of really specific reablement and rehab training that you want them to have, so they've got that mindset of, you know, discharge from the off and with supporting every day as a day of independence?
Yeah, so it's something that we initially struggle as well, was the mindset of the for example, the nurses we recruited that was used to work on a hospital setting or on a nursing home setting. Intermediate care units are a species of their own, so you need to train the nurses, and they need to understand each team involved within that intermediate care unit. So what we done is, and I worked closely with our hub team, was we did a day training where they will be with the hub team to understand their expectations of us. So and the social services as well, and be part of the NDTs, to understand what is needed to get these people home safely, and to keep them there independently as possible, because that is the aim of the intermediate care unit. And many nurses that we recruit have this mindset of treating but not reablement. So get them better. The aim is not to stay here. The aim is to get them home. So a lot of conversations around that is what I advise, to change that culture and to change that mindset. And this is what we've done in our intermediate care units.
Thank you. Richard in the chat Q&A has said, we have a pilot not called intermediate care where we provide beds which are still considered to be NHS beds, with their discharges controlled by the hub team / MDT home first with our team. There's a target of 2-week discharge home, and we provide the physiotherapy and OT and have access to NHS equipment ordering system. Works really well with faster discharges home and a higher percentage of patients going home. Thought you might like to see that option. I absolutely would, Richard. I don't know if I can pop my can I pop my email in the chat? Oh, I don't know. Lisa, perhaps we can capture Richard's email, because I'd like to know more about that. So Jenny Cook, one last question for you. Top tips, practicalities, planning for the next few months. What from your perspective of the journey that you've been on, I think there's probably two things. So from your perspective, what are you thinking are your top tips and your practicalities? And for systems and areas that are perhaps not where you are, what would be, you know, if you hadn't been involved in this, I know it's counterfactual and it's quite hard to answer, but what would you, if you hadn't had the benefit of this and you were looking at winter, what would be your top tips, practicalities?
So I think a couple of things. One is what I really started on, which is resisting that temptation that we all get at this time of year to add stuff into a already complex provision. So see a gap, add a service, see a gap, add a service, but to actually spend the time that we've got over the next few weeks and months to really understand the pathways and the processes that are in place, because the things that I've described as being able to achieve in Leeds so far, although there's been investment from a program perspective in terms of people making change, we haven't added new services or additional costs. This has been really driving better efficiency and quality from the stuff that already exists. And I know, yeah, although even we can be tempted to just add stuff on rather than really get into what we've already got. One of the other bit of this, which is kind of it's I guess a tip, but also a request, but also a reflection, which is one of the things that we've tried to create through the program, is a sense of accountability from all different partners about the end-to-end. So I guess really specifically relating to perhaps care, intermediate care bed providers in this context, is what we're asking providers to do is not just to, and I know this is a big ask, is not just to deliver really great care for the people that are in there, but actually to think about that whole, you know, the waiting list, the queue, the further end, because if actually every bit of the system only cares about the bit that they're responsible for and delivering it really well, that's how we get kind of blockages and the system doesn't always work and flow. So trying to create that sense of accountability for the waiting list and the queue and what happens afterwards, as well as the really good care in the setting itself, is really important. So there's a cultural element of that, which is recognizing that actually, you know, for that kind of population sense of responsibility, that it's about all the people that are in Leeds that might need intermediate care, not just the people that are in your care right now. And then there's a technical and data visibility, which is like, let's be able to see and describe what that is, because it's when you start to quantify it and see it really visibly, it can create a different sense. So that's a request and a tip, I guess, is like continue to create that culture of accountability of total pathways, not just delivering really, really good high quality service. That's obviously still an element of it, but so is the bigger picture.
Oh, absolutely. Seeing yourself as a critical piece of the jigsaw or a part of the glue or whatever phrase saying we want. Okay, well, I think I can't see any more questions in the chat. So any other final reflections before we draw to a close? And a request, Jenny Cook, I might pop up and see you up in Leeds at some point. I'm really interested in the different strands of your program. I think they sound fascinating. So
you're very welcome.
Thank you. So any final reflections, folks? Yes, Jenny?
Yeah, Liz, I just realized I put it in the wrong chat. I have to say the blueprint we find extremely helpful.
Great.
And everything that's in it aligns really, really well. So I suppose it's just an opportunity to say that that's something that I think has been a real positive over the last year, that there's been 2 publications that really sit and align side by side.
Thank you very much. We'll take that. Renata and Jenny C, any other final reflections?
No, I think these conversations are really interesting, and it actually shows that we all have the same aim. We just need to tweak a few things and understand each other's side. Like Jenny said, accountability, and in that service I was running, that was what was lacking from all sides. And then from difficult conversations, that is what Jenny Keane was saying, difficult conversations are needed, then we can move forward. So it's been really interesting. Thank you so much.
Great, thank you. Right, well, thank you to our viewers, audience, anyway, the lovely people who've been listening and watching. Thank you to Lisa and CMM for hosting us, and I will let you all go, give you 4 minutes back, and thank you so much for your time today, your insights and your reflections. We really appreciate it. Thank you, everybody.
Thank you. See you later.